I'm going to talk about some of OPM's experience in undertaking costing studies over the last, I think it's about 8 years. Although our focus is on universal health coverage, of course costing is a generic tool, and doing health service costings often has a number of objectives, and often the same study will serve more than one objective. So we might do costing in order to work out what the budget should be, how much we need to put aside for universal health coverage. But of course, costing is an important part, one part of economic evaluation. We might want to do costing, or often very detailed costing, to develop new payment tools, payment systems like case-based systems or hospital global budgets. And we might also want to do costing in order to understand efficiency, and how the efficiency varies across the sector. So there are a number of objectives. These obviously interlink, but it's important to know what we want. I think it's important to know what we want from the outset when we're deciding what type of costing study to do, because the type of costing study and the detail you'll go into the costs will depend on the ultimate objectives of the costing and what you want to do with it. Now, in principle, costing is very simple. It's all about a numerator and a denominator. The numerator is the total service costs. They may be costs of individual services, or they may be the global service costs. That's made up of two things, typically. One is service-specific costs, so the direct costs of providing a particular service, the drugs, the inputs of doctors and nurses and so forth. And then there are always shared costs. There's always a problem of sharing overhead costs between a number of services in order to come up with an accurate representation of actual costs. So that's on the cost side. In the denominator, we have the numbers of services, and how we count the number of services will vary, again depending on our objectives, depending on the type of service, but it might be procedures, it might be bed days, it might be patients, it might be case mix adjusted patients or admissions. And we put them together and we come up with a unit cost of services, so a numerator and a denominator. And OPM has undertaken, as I said, a number of studies over the years on costing. Some of these studies are in the table, which is also in the briefing on costing. And I've divided the costing studies that OPM's done into two parts. One is one are studies that have looked specifically at packages, the costs of essential packages, and studies have been done in Timor, in Indonesia, in Kenya and Kazakhstan. And those studies have come up with the costs of essential service packages. Now, and you can see figures there: $29, $22, $55. These are per capita costs of an essential package of services. Now, I don't particularly want to dwell on this. The actual numbers are not that important. They're out of date anyway now, because the studies are quite old. And I don't at all want to for you to go away with the impression that this is the cost of universal health coverage in those countries. These are very limited, typically very limited packages, mainly maternal, reproductive and child health services that we were asked to cost in these particular studies. We also did a couple of other studies which had a more generic purpose to look at the overall costs of the sector and come up with generic costs of surgeries, of admissions, of outpatients, as building blocks for other purposes, including provider payment systems. Now, one of the things, and Sophie's already alluded to this, one of the things that struck us as we did these costing studies over the years is the importance of taking into account the dynamic health system environment. And the importance of building into our costing studies and our costing models that dynamism. Costs are likely to change as things in the country change. One of the lessons we went away with, one of the things that we try to do in developing these costing studies was not only to come up with a sort of point estimates, if you like, but to come up with models that were able to incorporate some of the dynamic nature of the sector. And the rest of my presentation will focus on three aspects of the dynamic nature of costs to illustrate the importance, I hope, and show you how you might look at the dynamism in practice. So the first aspect of the dynamism, I can't say it today, the dynamism that needs to go into costing studies is incorporating the ability within the costing to take account of changes in coverage and changes in the population. And the sort of things that we might want to incorporate into the costing are things like coverage assumptions. So as you change the scope of the package, as you extend the package to a larger proportion of the population, of course costs will change, but not necessarily in a linear way. Because some costs are sunk, some costs are overhead, and often the marginal costs of extending services is not as great as the initial average cost. Things like demography, disease burden, access and use of facilities, so the patterns of services that we assume, numbers of facilities and the scope of services I mentioned already. So into our initial very simple numerator-denominator model, what we've tried to do in a number of these studies is to incorporate the dynamic that's inherent in the health system to enable us to come up with a model that will predict realistically the costs of extending coverage as the system evolves. So on the supply side, we incorporate things like changing technologies, changing protocols of treatment, factor costs, the costs of wages, costs of medicines. On the demand side, as I've said, we've got things like changing demography, changing epidemiology. And both those factors, and I'm not going to go into any detail here, but both those sets of factors interact both on the numerator and the denominator to affect the service costs and to affect the number of services demanded of the system, demanded of the health services, and ultimately affect the unit costs. And just to illustrate, I've got two approaches to doing that. Okay, let me talk about that first. I think there are two main approaches of incorporating the dynamic into the models. The first one is an accounting approach where we look at where we basically unpick the way in which the cost structures work, and we look at how the costs react to changes in numbers of patients, and we make assumptions in the model. So it's, if you like, it's changes to the spreadsheet formula to allow us to predict what happens when you scale up services or as you change the scope of the services. So that's an account, what I would call an accounting approach. A second approach is through statistical modelling. So this is looking what actually happens in the wild, if you like, what actually happens amongst a group of health service providers when those service providers increase the number of patients treated. Both, I think, have advantages and disadvantages. You can use them in different ways. But just to illustrate the importance of doing this, the screen captures the effect of the modelling that we did in Indonesia, looking at the per capita costs of an essential package in two areas, very different areas of Indonesia. So we applied the same model to the same package of services and worked out the per capita cost of that essential package. And one area of Indonesia is in Java, Yogyakarta, so it's a fairly developed part of Indonesia. The demographic structure is aging, so it's much less a pyramid. A lot of people go to retire in Yogyakarta. There are a lot of people go there to develop businesses. It has a very different epidemiology and a very different demography. We were looking at a package of services that was maternal child and communicable diseases, and the cost we estimated for the package was $15 per capita. And then we compared it to other parts of Indonesia. Here you've got North Maluku, which is still much more of a pyramid in terms of demography, a lot more communicable diseases, a lot more children, a much higher birth rate. And there we estimated the cost of the package was $48 per capita. So you see a threefold difference just by taking account of the differences in demography. And of course, demography is not static. So even with Yogyakarta or North Maluku, it will continue to change over the years. And we need a way of predicting the effect of that change within our costing estimates. Okay, so that's the first point. The second point, the second part of the dynamic, I think, is changes in the way services are provided. And again, I think there are two approaches to this. The first one is to take a service-by-service approach, to recognise that as systems evolve and as new technologies become available, the way in which treatments are provided is going to change. So a couple of examples, ART therapies are improving with better drugs. That changes the cost of the HIV part of the package. And to incorporate that, it can be very important, particularly in countries where HIV is extremely prevalent. Another example, more NCD probably. There's a trend towards much less invasive surgery. That changes the way in which surgery is done, the way in which anaesthetics are used. Again, that changes the component costs of the package. So that's a sort of direct way of dealing with the issues of changes in the way services are provided. There are also more general changes that might be incorporated into the costing. So, for example, in the Soviet Union, we've seen a huge but general reduction in the inpatient admission rates and in the length of stay, the time patients stay in hospital. And in some of the modelling that we've done, and it particularly applies to the Kazakhstan work that we did, we try to incorporate those very big changes, those fundamental changes into our costing. So an example from Kazakhstan, this is a model, or this is a picture of a model we developed in Kazakhstan to look at exactly the effect of those very big changes on the costs. And so what we simulated here was, the details, it doesn't matter, you can't see the details too much, but what we simulated here was a reduction in the general inpatient rates, and the assumption that many more patients would be treated at the outpatient level rather than at an inpatient level. And in fact, here we simulated a reduction in the inpatient rate of 30%, and then the figures circled show the effect effect of that on the total costs of services. There was a reduction in service costs, although the reduction wasn't as great as we perhaps imagined, because patients were not using hospitals so much, but they were then being funneled into the outpatient level, and that obviously has a cost, maybe not so high as inpatients. Okay, so that was the second part of the dynamic. The third part of the dynamic is that if we're not careful, costing studies can easily incorporate unnecessary inefficiencies in provision into the cost estimates. So the static cost estimates, the $15 or the $40, may easily incorporate a lot of inefficiency. And so the issue is, well, we know that, we can see that. What do we do about that? And I think there are a couple of approaches. The types of inefficiency that might be incorporated are firstly the product of inappropriate treatments. So a lot of what's happening in the health sector may be done inappropriately, either inappropriate therapies generally, or for a particular treatment, too many drugs given, too much time spent with the patient, or not enough time spent with the patient by particular cadres of staff. So there's inefficiencies introduced as a result of inappropriate treatment. There's also inefficiencies introduced as a result of low volumes. One of the big drivers to the unit cost always is the volume of services, and it's almost an obvious point that if you increase the throughput of patients, your unit costs tend to fall, because you're sharing the fixed costs between a larger number of patients. And a lot of the inefficiency is introduced as a result of those low volumes. Now we have to be careful about that, and we have to be careful because often low volumes are something we put up with in order to deliver equity in certain areas, equity and access. So we might say we might put up with low volumes in particular areas which are sparsely populated, where patients would have very little access to treatment if those services weren't provided. That's why I said on the previous page that it's about unnecessary inefficiencies. So when doing our simulations, we have to be careful. I think there are two ways of dealing with the efficiency, and it's really back to the normative and the actual again. One way to deal with, or at least to look at inefficiency, is to undertake efficiency modelling amongst facilities. So techniques, quantitative techniques of data envelopment analysis, stochastic frontier analysis, basically help us to look at the best performance amongst a class of facilities. So example here is a group of Indonesian hospitals from our Indonesian costing study, and this is a data envelopment analysis that is being undertaken by a student at Leeds who's using the data at the moment, and the idea here is that health services, health providers can be thought of as multi-product firms. They produce more than one thing. Here we've simplified the multi-product into two products. One is inpatients, or bed days, on the vertical axis, and the other one is outpatient visits or ambulatory visits on the horizontal axis. And some health facilities do a lot of outpatient and very little inpatient. Some do a lot of inpatient but very little outpatient. Some do a mix. The idea of these techniques, these quantitative techniques, is to look at, to identify the health facilities that are performing at the best given the resources that they have. They're performing at a frontier. And so what we trace is a frontier that marks out the facilities that are best performing. And then all the other facilities, all these other dots within the frontier are providers that, if you like, could do better. But then the next stage of the analysis is to find out why all these providers could do better or aren't doing better. And part of that may be what I said earlier, which is that they're providing services to sparsely populated areas. So we put up with the inefficiency or the low productivity. But in other cases, there may be things that we can do to help those facilities push towards the frontier. Now, the problem with this approach is that we're constrained by current practice. And it may be that none of the facilities, even the best performing facilities, that none of the facilities are adopting in some for certain diseases, certain therapies, they're not adopting the best practice interventions. So we can only using this approach we can only look at what goes on at the moment. So the second way of dealing with inefficiency is to look in detail at the content of what individual facilities are doing, and to make what I call normative adjustments. So look at how a particular service is provided in the field, and then consult with experts about how that service should be provided if it was done based on the best evidence or the best protocols, and alter the costs accordingly, alter the inputs and therefore the costs accordingly. We can model that. That can be quite a powerful technique, although we have to be careful, because just because an expert says something should happen doesn't mean it will happen. So we then, the onus is then on implementers to think about how those practices could be adopted by health providers. Okay, so I've about done. I've covered three aspects of the dynamism that needs to be in any costing study. Then there are probably other aspects, but those to me were the most important. Some of the things we might want to discuss when we come back to the discussion include, firstly, the level of detail in costing. I think this is a really important point, because costing studies can be enormously costly. And if the main objective is to do a quick and dirty, a rough idea of the costs of universal health coverage, then it's probably not necessary to undertake a huge multi-million pound or survey of many facilities in order to get there. On the other hand, if the idea is to deliver a cost study that not only answers the costs of UHC question, but also begins to develop a system you can use for things like provider payment in the future, then it may well be a good idea to invest. So again, it's back to the objectives of the costing. Another one, the second issue for discussion is the extent to which we should use normative or actual costs. So it goes back to several of my points made earlier. Do we look at what happens now, or do we make adjustment for expert opinion? And the final one, I think this is really interesting to me, because I'm not sure that I've ever done it. And that is, whenever I've started costing studies, there's always been everyone has always been very keen that as much as possible we use routine data, and that we try and we help develop the routine data into the future so that costs can become more routine, can become more embedded in the system. And I think that's a great principle, but it requires a huge investment in time and in systems, and I've never seen it done very well, at least in the countries that I've looked at. But I still think it's a very important issue for the future. Thank you.